So vascular anomalies, what do you guys know about vascular? What's any idea what a vascular anomaly, an example of a vascular anomaly? Yes, AVM is it's interesting that usually is the first thing that comes to everybody's minds when you talk about vascular anomaly, but is one of the most rare vascular anomalies. Although it's I think the name, I don't know, but it's a very common name used throughout a lot of diagnostic studies, a lot of discussions, and they're not applied correctly to what the patient actually has. So vascular anomaly is a really big group of disease or problems that can be divided in two big groups, different groups. The first one group is vascular tumors, and then the other one is vascular malformations. Okay. What is the biggest difference between a vascular tumor and a vascular malformation? In 30 years. Yeah. Vascular tumor, as the name says, is a tumor. It's a proliferation of cells that are not supposed to be getting big and in increased numbers. Okay, so there is cell turnover and something is growing, right? Vascular malformation, on the other hand, is something that was not formed the way they're supposed to be. It can have a mass effect as a tumor, but there's no cell proliferation on that. Okay? And vascular malformations, by definition, are congenital problems. Whatever led to the malformation happened intrauterus. So patients were born with that. They may not see that they have a vascular malformation, it might be pretty small and hidden and deep, but it was there since the beginning. Vascular tumors can be both. You can be born with vascular tumor, or a lot of times, most of the times, you're completely normal at birth, and you will acquire that over time. Okay, so the things to keep in mind. And then, as every tumor, we have benign tumors, we have malignant tumors, and we have something in between. For vascular tumors, the same. We have benign vascular tumors, we have very malignant vascular tumors, and we have borderline stuff. And the vascular malformation it can be pretty complex, the definition or the classification, but very common. It depends on what type of vessel the malformation is coming from. It's from a vein, we call venous malformation. If it's from a lymphatic vessel, we call lymphatic malformation. If it's from a capillary vessel, we call capillary malformation. And if it involves an artery, we call arteriovenous malformation, because by definition, there's always a communication between the artery and the vein. So that's why we call arteriovenous malformation. Okay. So if you guys could just be able to recognize this big group and then how it can be divided, it's a great start to understand and know how to talk to patients and referring physicians and try to kind of put this frame in your mind to how to address vascular anomalies. Right? Just a quick, so the most common vascular tumor, it's a benign one, is the hemangioma. That's another word that I'm sure you have heard a lot, and you're gonna be hearing a lot throughout your medical career. And I'll tell you, 80%, 80-90% of the time, it's applied wrongly. So everything that seems vascular, somebody will call hemangioma, but it's not true, right? So hemangioma, infantile hemangioma, is the most common vascular tumor, but there is a very specific clinical picture that the patient needs to have in order to say, yeah, this is a hemangioma. It's very classic, okay? And we also have what we call infantile hemangioma. It's interesting that the patients, they were not born with that. They will develop later on after around a few weeks of life. Congenital hemangiomas, less common, but the patient will be born with that. Okay. And then vascular malformation. So the venous malformation is the most common one. Lymphatic malformation comes second, and as I mentioned before, arteriovenous malformation is the rarest one. Although that's what we call a lot of time what the patient. Okay. This is a graph that shows how, in terms of clinical history, how can we differentiate vascular tumors and vascular malformation? Vascular, especially the infantile hemangioma, which is the most common one. The infantile hemangioma at birth, this is the curve of the infantile hemangioma, years and growth and size. So at birth, you don't see that. At around 1 month of life, that's going to see the increased size of the tumor. It will peak around 6 months, 1 year. And then by 5 years of age, it's gone. Classic infantile hemangioma, it's gone. So every patient that is older than 5, you have a patient 13, 14, 20, 30 years old with a vascular mass, don't call infantile hemangioma. It's not. Although that's the names is going to see pretty much all report that the patient is going to get. Okay. Infantile hemangioma by the age of 5 is gone. Vascular malformation is different, so it's present before birth. You may not see or see at birth. And over time, the size keeps growing. Instead of regressing, it keeps growing. So that's a very good way to define a vascular tumor from a vascular malformation, right? All right, so just a little picture that an infant that was born completely normal and then shows up a few weeks later with this mass on the head. So this is a classic example of an infantile hemangioma. It's a very classic. Okay, born, no lesion. Around a few weeks of age, they start to see a little small spot. It grows rapidly in the first few months, reaches a peak around 1 year, and then after that starts to decrease. Okay. So this patient was born with this lesion, a very big tumor, very vascular. The patient was born with that. And when you see the ultrasound, you see that you have like a parenchyma going, you have cell proliferation there. So this is what we call congenital hemangioma. The patient was born with that. This is another example of a patient that 16 years old has this mass that is getting bigger and bigger over time. There's no pulse. You put your hands there. It's compressible. You don't see a pulse. It takes a tumor malformation. It's growing over time, has been there. First noticed around 1 year of age, and slowly it's getting bigger. This is a classic example of a venous malformation, right? It was seen early on in life. It's getting bigger over time. You don't feel a pulse. It means that there's not an arterial component on that. So this is a venous malformation. It is a different patient that comes with this mass in the lip that is getting bigger as well. Was noticed very early in life and it's getting bigger over time. But when you do your examination, you feel pulsation. You feel that the mass is pulsatile. So that means there is a arterial component on that. So that's a arteriovenous malformation. So most of the times, just by looking at the patient and get a good HMP, you can make a differentiation. You can make your diagnosis. You don't need radiology to get your answer. Okay, so this is an important thing to notice. So here, we'll take a break. Once more pizza. You guys good? Yeah. So, well, let me see. And how do you guys think IR can get involved with that? So why an IR physician is talking about vascular malformations or vascular tumors?
The tumors can cut off circulation, so you might need to stent that pathway open.
Yeah, that's one of the reasons.
From a therapeutic standpoint, I feel like vascular or IR is the best situated to take care of this disease.
Yes, yeah, that's a good option. So first of all, we get involved because a lot of times people don't know what they're dealing with, and then they order studies and there's specific protocols that needs to be used to define, to try to find out what type of malformation we're dealing with, how extensive the malformation is, and have a treatment plan. As I mentioned before, most of the times, just by having a good HMP, you can find your diagnosis, and the imaging will be for treatment plan, right? So that's the way. MRI is usually the best study to look for vascular anomalies and see how deep they go, how extensive they go, what important structures they're close by, because all of that will affect your treatment plan. For example, this is a very superficial, it's a large but superficial venous malformation that involves only the subcutaneous tissue. It doesn't go deeper in the musculature or inside the cavity. So it will be a relatively easy one to be resected, for example, right? Although the size might be really big. So this one is another one that the MRI can tell us that the malformation, this MRI of the knee, sagittal view, the malformation, the MRI can tell us that the malformation extends into the articular space, which changes the prognosis of the patient. It's different if this malformation, for example, bleeds, will get came back pretty painful, but over time will resolve and won't have any further issues with the patient. If a patient had some bleeding inside the articular space, this can be bad. So over time, the patient will develop osteoarthritis. So it helps us define the prognosis as well. Okay, we don't need the MRI to tell that this is a venous malformation, but the MRI helps determine the prognosis of the problem. Okay, that's an MRI of the foot. Is a kind of a sagittal or coronal view of the foot, and this is the entire malformation involving pretty much all the tendons and muscles of the patient. So if you compare this malformation to this malformation, which one is easier to resect? And it will cause less problem for resection. So this one, if you resect that, the foot is not going to be functional anymore. So you're going to resect all the muscles, tendons. So resection is not an option in this case, right? Then you need to think about other options, how to treat those. Okay. This is too much in the details. I'm gonna switch for the other talk here. So, any questions about overall vascular malformations and vascular tumors?
Are there any specific, windows that are better to treat or really important to treat? Like if a child's younger than 5, want to wait until.
Yeah, that's a great question. So treating those malformations, first of all, it's in theory it's a benign disease. So you only need to treat most of the time the ones that are symptomatic, and the symptoms that are associated with malformations are pain, discomfort, functional limitations. Sometimes the patient cannot extend the entire arm or the knee, and they cannot play sports because of the malformation. So that's indication to treat. The other one that becomes more common as the patient gets older is cosmetic. So those are the reasons to treat, most common reasons to treat malformation. The other one is even the ones that are not symptomatic at all, but they're in the location that may cause a problem in the future, you can also treat. For example, that one in close to the knee. Malformations close to the airway. When you have, they can bleed and can cause obstruction of the airway, for example. You treat those even if the patient are completely asymptomatic, okay? Even if they can be just a newborn, you should treat those. Okay, so there's not a window, it depends on symptoms and depends on how bad it can be if the malformation gets bigger, right? And I mentioned surgery is a way to treat, but another way and very common way, and actually most common way to treat those malformations is by IR techniques. And it always depends on the flow, okay? If you have a very high flow situation compared to a low flow situation, or a low flow situation like this, the type of approach you're going to take is different. If you're trying to embolize something or deploy a device or inject a liquid or a liquid drug inside a vessel, it varies if you're in a vessel that is flying with blood or in a vessel that is a really stagnant flow. Okay? So this is a situation where an arteriovenous malformation is going to look like, and this is a lymphatic malformation or venous malformation. So based on that, you can use different approaches. High flow lesions, AVM, so vascular tumors can be very high flow. If you get those infantile hemangiomas in that early phase, they can be very, very hypervascular. Okay? And low flow venous and lymphatic malformation. So this is a kind of quick example of a high flow lesion. This is an artery. The artery is really big. You have a nidus and you have a outflow vein. So the flow, the blood is just flying there. And you need to be careful how type of agents you're going to use to block those vessels, because you don't want that to go distal in the heart. So this is a patient that had a arteriovenous malformation at the hand. So we have a catheter all the way down, coming from the groin all the way up here. A microcatheter. This is the ulnar artery. We're getting distal there, and this is the, I don't know if you can see, but this is a microcatheter, and we're pretty much inside the malformation there. This is the forefinger. From there, we used a embolic agent called onyx. Is a liquid embolic agent that travels, that has some pushability to go distal in the small abnormal vessels, but they can also solidify pretty quickly to avoid that to go too quick into the heart. So this is the picture before the embolization. Had a pretty large lesion here, and this is the after the embolization. You still have some vessels, but most of the malformation is gone. So the other thing that's important to talk to patients about this is it's very hard to cure them from this, or there's pretty much no way to cure those patients from any vascular malformation. The goal of any treatment is to get those symptoms under control. Okay? So this is another example of a patient with a pulmonary AVM. Have you ever guys heard about that, pulmonary AVMs? Okay, what's the problem of those? Or what symptoms they can cause? Hemoptysis is one. Yeah, you can, but why the patients who have shortness of breath? Yeah, actually, it's not compressions, because if you have a malformation, there's no gas exchange. If it's a large malformation, most of the gas will be bypassing the pulmonary capillaries, and this O2 sats on the patients can be pretty low. Right? That's the reason they get small malformations like this. They usually don't cause shortness of breath, but some patients may have multiple or big ones that will cause the O2 sat to drop. What is the other very problematic issue with pulmonary AVMs? Think about blood shunting. So stroke is a problem. If a patient has a DVT and a pulmonary AVM, instead of having PE, the patient will can have a stroke, because depending on the size of the vessel and the shunt and the communication, that clot can go into the left atrium, left ventricle, aorta, and brain. Right. So at the end, the lungs will work as a filter to prevent that. But then if you have a communication between the pulmonary artery and the pulmonary vein, that blood will be bypassed, and whatever is in the leg, whatever, can go to the brain. The patients can have stroke, they can have bowel ischemia from emboli, kidney embolization, all those issues with arterial embolization. Okay. So that's the reason, depending on the size, and there's a cutoff, usually above 2 millimeters of feeding vessel. Those need to be closed to decrease the risk of stroke, right? So yes, 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 all right. So in this patient, we I suppose you have a video here. I'm not sure it's gonna. No, it's not working. Sorry, guys. So yeah, sorry. So, but we came here from the IJ, get a cath in the right atrium, right ventricle, pulmonary artery, right pulmonary artery. We did a run there. I can see the malformation, and then we can deploy some coils to block that blood flow, and then stop the malformation. I'm sorry, but I thought the video was going to play. Sorry. So in those high flow lesions, there are different type of embolic agents we can use. It always depends on how fast the flow is and how control you need to have. Those coils, they're large devices, but you can control the deployment. You can push the coils out of the cath inside the vessel and see how they sit, and then you can deploy them. Or if you don't feel like it's a good location, or if you feel like it's not stable enough, you can recapture them and then use a different device. So that's something that we have in our arsenal to help this patient. Okay. We have liquid embolic agents, as I mentioned, the onyx or glue that you just push, just a viscous material that, depending on how fast it is, you can use those devices as well. And for low flow situations, so for high flow, what we usually talk is about embolization. You get into the arterial size and you embolize, you block the blood supply to that area. On the other hand, for the high flow or low flow lesions, we talk about sclerotherapy, which is a procedure that we stick a needle direct into the malformation. Right. So here, as an example. So there's an ultrasound guided procedure. We inject a needle, put a needle inside the malformation, and then we put some contrast. You see the contrast on the fluoroscopy. You define your anatomy, but then with the needle, you inject a sclerose agent inside the malformation. Usually, the sotradecol, or can inject alcohol. And the goal of the sclerose agent is to scar down the vessel. At the end, over time, you just block down that malformation. Okay. So ideally, you get access in as many vessels as you can, or you push that liquid agent as much as you can to cover the malformation. You often need to bring the patient back multiple times for multiple sessions, because there's a limited amount of liquid you can inject per session. And the more you inject, the more complications you may have. So those are all the sclerose agents that can be used. Alcohol, very common one. Sotradecol nowadays is the most common one use, bleomycin, doxycycline. Doxycycline is a good one for lymphatic malformation. And sometimes we can use ablation, either for laser energy or radio frequency. But that's another clinical example of malformation on the around the knee. Yeah, one more video doesn't work. Sorry, guys. But we can inject, put a needle straight into the malformation, inject contrast to define the anatomy, and then slowly inject our sclerosing agent. Okay. So this is an example of a lymphatic malformation. The patient comes to the clinic with a big mass in the groin. This is an MRI, pre and post contrast. The T2 sequence had that bright lesion there, close, same brightness as the bladder. Whatever is liquid in the T2 sequence will be bright. Right? And then when we inject contrast, we don't see any opacification of the malformation. That means that it's a cystic lesion. And that's a classic sign of a lymphatic malformation. So with that, we can inject. So this is a picture of us. This is the needle we injecting, get access on the ultrasound guidance and inject contrast. And then we can inject a mixture of contrast and the sclerosing agent to define how much are we covering. And then the patient can go home the same day of this procedure. So this is the pictures before and after. So this is before the groin area and now more in the mid thigh. And that's after a few sessions. And this is how small we got. Here got a little bit small, but still there. But the important thing is that the patient at that time was asymptomatic, not complaining of discomfort, not complaining on any cosmetic issues. So, and that's our end point. Okay, you don't need that. You can't treat and completely get away with those lesions, but you treat to a point that the patient is not symptomatic anymore. So that's another example of a malformation. See if, as you can see here, just a big long vessel that is abnormal and was causing pain. The problem, what's the problem injecting a sclerosing agent here? Injecting a liquid agent there. In this case here is inject is a cystic lesion. All the sclerosing agent is stuck in the malformation. Right? If you inject anything that you inject is, as we're injecting contrast, gonna go to a normal vein, a normal circulation. So when this specific type of malformation that you have a very direct connection between the malformation and the normal system, you need to be very careful using liquid agent because you don't have control of that. Once you inject, it goes away. So in order to treat this one, we use a technique that calls, sometimes you can block that compress, but then usually it will find another pathway to the normal circulation. So even if you compress if you inject the agent, we will go to the normal vein. So in this case, we use a specific device called laser ablation. It's a catheter that you put it in, and it deploys a heat around the catheter and then burns the vein from the inside. So you only place the catheter on the abnormal segment of the vein and then burn that vein, and then there's no risk to shooting that agent up in the normal circulation. Okay, so you can use, as I said, embolization usually for arterial lesions that has a high flow, and you can use sclerosing agents and sclerotherapy for slow or low flow malformations. And here at MSC, we meet every month. There's a vascular anomaly program. So we meet every month with dermatology, surgery, ENT, oncology, peds oncology, to try to go over many cases. Every month we have one. We have one yesterday actually. We have around 5-6 patients new patients that we talk and discuss what would be the best approach, surgery, medical management, IR techniques. So it's a very unique area that not a lot of places are familiar with. So usually big academic centers will have a program like this, and we have one of here at MPC. Questions? Yeah.
What's typically the biggest complication in clearing vascular?
Yeah, can be very bad complications. Sclerotherapy, things that I worry about the most are on the sclerotherapy, depend on what agent you're using. And if you're using alcohol, for example, it has been described as sudden cardiac arrest. If too much alcohol goes into at the end, all that drug is going to go to the lungs. If too much goes to the lungs, you can have acute pulmonary thrombosis, and the patient can code in front of you. So there's a specific amount that you can inject. If you're not careful, these are the complications that has been described. Okay. Other complications of sclerotherapy are if the malformation is too close to nerves, that sclerose agent can damage the nerves. More common with alcohol as well. And then most of the times it's okay, but if it happens, it's a temporary, but very rare can be a permanent nerve damage. And if it's too close to the skin, you can have skin ulceration as well. Yes. Yeah. So it's based on weight. So per session, you can use up to 1 cc per kg, which can be a lot, depend on how big the patient is. But there has been some studies that if you use a tenth of that, 0.1 cc per kg, you will never have a cardiac arrest on the table. So I usually capture to that. Okay, that's one of the reasons you at the end you need to bring the patient multiple times to the procedure. On the embolization side, whenever we do embolization, the major concern that we have is at the end we're blocking vessels that are not working. The problem is if you block vessels that are normal and you need them to function. And then if that happens, you can have distal ischemia. Right? If you're treating a malformation in the leg, if you block the major supply, you can have leg ischemia that patients might you need to do a thrombectomy or a bypass, and at the end patient might lose their legs. So that's the complication. Yeah.
So like also on like the arterial or embolization side, do you also need multiple treatments there, like on the venous side, or is that typically less?
No, sometimes you always depend how big the malformation is, but typically you need more than one treatment session.
What does that look like in multiple sessions?
Usually I do the procedure, I see those patients 1 month later in clinic, and then we reassess how they're doing clinically. And then we can schedule next one if needed right there, right, for a couple of weeks before. It always depends on patient availability, family availability. There's always schools involved because it's usually a young kid. But you can have those procedures done every 6 weeks if needed.
Is there ever a situation where you would have to consult vascular surgery with a professional approach, or do you mostly take care of it?
Most you can do by IR techniques, but sometimes sometimes we discuss vascular surgery, and as I said, it's a multidisciplinary approach, and a lot of times vascular surgery is somehow involved. But personally, I never be in a procedure that at the same time with vascular surgery, but this is something that has happened before in other institutions that they depend on how the anatomy is and what should be done.
You said this isn't usually like a solution necessarily. Does that mean it might reoccur?
Yeah.
And if so, how far do you follow it? Yeah.
Forever. Yeah. So those patients need to have a follow-up for for life. Even if we get a pretty good response initially, they may recur later on. Usually those malformations, they respond to hormones, and they have a natural history similar to the patient's growth. So when they're gonna get older, they kind of stabilize. And then if the patient is not symptomatic, and they most likely won't be later on, but something that needs to be followed for life. All right, guys. Mm, yeah.
How many interventional radiologists are doing these types of procedures? Like, is this just an academic application?
Yeah, there are some private practice that does that, but at the end, it will be most likely in a big academic center. For example, here at MSC, we have right now 6 IR attendings. Right? I'm the only one that is doing this. And I think the more you do, the more experience you get. So, and this is not a very common uh, patient that you see every day. So you start to, it's good to build up a practice that only one does until he cannot do, it's too busy to get done, and then you have other people joining in. But this is not something that you will do one time, and then a year later you're going to see another patient and do it. That's usually not the way it works, because you need to be doing that constantly. You're constantly involved with those patients to be able to manage that appropriately. In that last meeting, that's what we had. Usually new patients, right, that they come to for the discussion, but then once they're in, we have constant follow. For example, I have one clinic. My clinic days on Tuesday, one day of clinic per week. I see about 10, 12 patients, and I would say that maybe half of them are malformation of vascular anomaly patient, either initial visit or follow-ups.
So do most people in IR almost inform specialized on it?
Yeah, nowadays it's becoming more and more common, because first of all, the volume of patients are getting bigger, and it's the type of treatments are becoming more complex and more specific. So there is a trend of IR being specialized in specific things. Here we do everything of everything originally, because when you're on call, for example, you need to be proficient in doing whatever comes out the door you need to be doing. But for outpatients, for example, I'm the one doing those PEDS cases. We have one of the attendings that start doing the prostate artery embolization, for example. And whenever we have a new procedure, a new service line, you won't have as many patients that everybody can be sharing. So you kind of focus on one attending. That person becomes the lead person on that. And then you start to split the volume as the volume grows. But you tend to have specific niches. For every attending has a specific niche or a specific interest that they want to devote their time for. But at the end, it's more and more common to have a specific area in IR. Yeah, it's first of all, you define internally in your heart what you want to do. If you feel like you want to deal with PEDS IR, for example, and then recruiting those patients is there's a lot of conversation with referring physicians, primary cares, oncologists, and be available and expose yourself. And it's at the end, there's a lot of marketing that you need to do. Market yourself that you're there, you're available, you're interested in this. A lot comes from your research productivity. If you start to study and publish a lot on a specific topic, over time your name will become related to that topic. People will ask you to come and talk about that in a meeting, on a conference, or give lecture to. each other. And that's how people get to know you and how you kind of start to establish your niche. A lot of times you'll go into an institution that needs somebody to do specific things, and then you put yourself available to do that if you want. Yeah, no, well, here I mean, it's a little bit different because being the biggest academic center in the state, uh, most of our referrals come from outside primary care or physicians or pediatricians that they don't know what to do with their patients. A lot of time they send to IR. A lot of time they send to dermatology or peds oncology. But at the end, we funnel all those patients to the vascular anomaly program, and all of them are kind of discussed and in that meeting. So we're all get involved at least, even if is it clear that the best approach is sclerotherapy, for example. The patient will be discussed in this meeting and will be kind of linked to the program. Yeah, I think that happens for the tumor boards, even adult patients that are referred for cancer, and they're funneled here, but at the end there's a MUSC tumor board discussion or institutional discussion, and this patient becomes a MUSC patient, not my patient or somebody else's patient, becomes a MUSC patient. All right, guys, hope that was helpful. The pizza was awesome, as always. All right, thank you, guys.